Hi, everyone. We're just waiting for folks to join and we will begin shortly. So stand by. We appreciate everyone joining us. We're going to start in just a few minutes. Just waiting for everyone to come in. All right, we're about a minute in, 9:01. Folks are joining, so thank you so much. We're going to get started. Hi, everyone. I'm Desiree Behringer-Carton. Welcome, bienvenidos. I am the Director of Regional Integrated Marketing and Communications for the American Cancer Society. It is my pleasure and honor to welcome you to the event today. So we ask that if you've called in from a phone that you please enter your name and organization in the Q&A. So we have a record of your attendance. All lines will be muted during the program, and we ask that all questions be entered in the Q&A tab on your screen. So we will be taking questions during the panel discussion at the end as time permits. So if we do not have time to answer your question during the Q&A, we will work with the presenters, to have your questions answered post-event. So thank you for that. So again, welcome. We are so happy to have you here with us today. We're going to have several poll questions throughout the program and appreciate your participation. So please answer our first poll question that will appear on the screen. What sector do you represent? And so you'll see that, and I'm going to, I get to fill it out too, which is awesome. Nope, I go. Okay. So you see your options there, so fill those out. Thank you. Okay, so before we begin our program, we wanted to recognize and thank our wonderful sponsors. And without the generous support of the Ohio State University and United Healthcare, this program would not be possible. So we really appreciate it. Oh, you can see right there, we'll have our poll questions, our answers come up later. But we want to thank you for that, for our sponsors. So just so you guys, before we keep thanking our sponsors, 75% of you are from hospital systems, 2% from state and local health departments. We have community organizations, 11%, cancer survivor, 5%. We have a mix of folks from everywhere, providers, 2%. So thanks for everyone filling that out. But again, thank you to our sponsors. At Ohio State University United Healthcare Program. Also want to thank the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. So we couldn't do it without you. So thank you so much. So I think we jumped ahead, but the agenda right there. So here's the agenda for today. We'll have 4 presentations followed by our panel discussion, and we will conclude with information on American Cancer Society resources. So we appreciate that. And then just so you know, the AAFP has reviewed navigating issues in early onset cancers webinar are deemed they're deemed acceptable for up to 2.00 enduring material self-study AAFP prescribed credits. So you will receive a certificate to claim your continuing education 2 weeks following completion of the post-event survey. So just keep that in mind. And our objectives for today's program can be seen on the current slides. So please note that Dr. Flora would like to disclose the conflicts of interest as seen on the screen. The remaining planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organizations that may affect balance, independency, objectivity, or scientific rigor for this continuing education event. So also please know that the slides will be available after the presentation, and this event is being recorded. So now it's time for our second poll before we get to our wonderful speakers. So how confident are you with the knowledge of early onset cancers and issuings surrounding them? It's just one choice. So you can see that there, right there. All right, and thank you for answering the poll question. So it is my honor. We want to welcome our first presenter, Stacy Hurt. Stacy holds a bachelor's degree in labor and industrial relations from Penn State University and a master's degree in health administration and business administration from the University of Pittsburgh. So Stacy ensures that patients and caregivers have a seat at the table to translate their experiences and recommendations into improvements in the drug development process at its earliest stages. She brings a very unique perspective as a cancer survivor, caregiver to her son, who is an ultra rare genetic chromosome abnormality. And she is also a global patient advocate. So formally, Parexel's patient ambassador, Stacy uses her voice to represent patients everywhere, even when they are not in the room. So her highly sought out, after insights, shape strategies for clinical trial in the design and delivery. So she's an award-winning 25-year pharma executive with experience in functional areas such as sales, marketing, training, operations, and physician practice management. That is quite the resume, Stacy. And it is just our pleasure to have you here. And we are so thankful for you sharing your journey and talking to us. So welcome.
Thank you, Desiree. I'm supposed to be on camera. I'm not spotlighted yet, so hopefully
Okay,
I'll come on screen.
there
There I am.
you are.
Hey.
Wonderful. Thank you.
Oh, Desiree, thank you so much. I got to shorten that bio. Boy, that's a lot.
Well, that's
But
wonderful to hear, and we needed to hear it. So thank you.
oh, everyone, I begin every presentation that I give with gratitude. I always begin with gratitude. So I just want to thank you for joining us today in this important conversation about early age onset cancer, one that is personally important to me. You'll hear my story in a minute, but one that we all need to join together to face and to understand. But anyhow, my name is Stacy Hurt. Professionally, yes, I am Chief Patient Officer for Parexel. Parexel is a global clinical research organization, and what we do is we partner with pharmaceutical and biotech companies around the world to help them run clinical trials for patients and caregivers in need of better treatments and cures and better options. So let me start professionally. As you heard in my bio, I've been on both sides of the equation. I have worked in healthcare. I'm based in Pittsburgh, Pennsylvania. As you heard, went to Penn State, 2 master's degrees from Pitt, and been in various functions in healthcare along 25 years. And you'll hear in a second why I'm proud to say that I'm 53 and alive and well. So I was on that side of the equation. But it was really when I became a caregiver and a patient that completely changed my lens of healthcare. So I have 2 sons, my older son, Griffin, who just graduated from Pitt, and my younger son, Emmett, who was born in 2005. And when he missed all of his 6-month milestones, we went into a diagnostic odyssey, a rare disease journey to find him a diagnosis. And he does have a rare chromosome disorder. He's one of 3 known cases in the world. It is a 1q duplication syndrome, so rare it doesn't have a name. But how it affects Emmett is he's 18 now, and he does not walk, talk, or do anything for himself in any way. He is entirely dependent on my husband of thankfully 25 years this year and a home health nurse for all activities of daily living. We diaper him, we feed him, we lift him. He wears ankle braces. He is an aspiration risk. He's medically fragile, medically complex. And so our lives revolve around Emmett. And as I will tell you as a caregiver, it is the most rewarding and important job that I never asked for. I've told Emmett's story 1,000 times, and I always get emotional because he is the most important part of my life. Everything else comes secondary to Emmett, but he is happy. And although he doesn't talk, he has big blue eyes and he looks at us and he knows he's loved, and we love him so much. So like I said, first I became a caregiver, then I went back to work. I carried the bag for 10 years for Merck and GlaxoSmithKline as a pharmaceutical rep. I got into training and development, and I was heading up a smaller pharmaceutical company, training and development, when in 2014, I started experiencing symptoms of fatigue, cramping, blood in my stool, pain. And what you have to know about me is that I am a lifelong athlete. I played volleyball and basketball in high school. I'm very fit. I'm a non-smoker. I'm a healthy eater. Really one of the healthiest people that you could have met at age 43. So when I was experiencing these symptoms, I went to my PCP and she said, I think this is internal hemorrhoids because you're so healthy, but I'm going to order a colonoscopy just to be sure. And thankfully she did. That colonoscopy saved my life because unfortunately it was the worst case scenario. On my colonoscopy, the GI had to abort the procedure because he could not get the scope around what was an 11-centimeter tumor in my rectum. He woke me up and told me the 3 worst words that nobody wants to hear: you have cancer. And I said, I don't even know how this happens. I'm young, I'm healthy. How does this even happen? And he said, it just happens. A subsequent PET scan revealed that I had cancer in 27 places in my body: rectum, liver, lungs, lymph nodes. It was advanced metastatic cancer, stage 4. I had an 8% chance of living 5 years. The result of my PET scan came back on my 44th birthday, September 17th, 2014. My older son was 10. My younger son with special needs was 8. My 10-year-old son asked me, we were very transparent with my diagnosis, and he asked me, Mom, are you going to die? Toughest thing I've had to go through to date, even tougher than battling cancer, was hearing that from my son. And I said, no, when you get your braces off, I'm going to be through this. And meanwhile, I was scared to death because I had no idea if I was going to get through it. But I can tell you that going through 55 chemotherapies of FOLFOX, which was standard of care, which I was fortunate to respond to, another drug called Avastin that was added to my treatment, cyberknife radiation to my lungs, 2 surgeries that was supposed to be 1. Unfortunately, we had a medical accident where a blood vessel was nicked during surgery. I incurred internal bleeding, lost half of my blood volume, coded, went into cardiac arrest and almost died. Came back from that with a couple of blood transfusions, woke up in the ICU, endured more chemotherapy. And friends, this story has a happy ending because I am 9 years cancer-free. So I'm thriving and surviving and doing really well and here with my family. But through that journey, again, which changed my view of healthcare again, I realized there were huge gaps between those of us who work in healthcare and those of us who receive healthcare. So I became very, very active in patient advocacy. And yes, that's me on Times Square. It's Big Stacy. But I engaged in a lot of advocacy groups, online communities, connecting with patients. And because I could speak the language of the system, I was able to help patients speak up for themselves and advocate for themselves and have a voice. This translated into me forging my own business and opening my own business upon my cancer recovery into what's now known as patient engagement. And the work that I did was indeed working with pharma, biotech, healthcare systems to help them understand what patients need. And like I said, I'm very proud now to be with Parexel and to be Chief Patient Officer and represent patient and caregiver needs as these stakeholder groups, as these people go through clinical trials. And we break down barriers for those who want to be included in clinical research, including our most vulnerable and underserved populations who we're not doing a good job of representing, only 5%, and we need to do better. But that is my whole story. I'm really pleased to be with you today and talk specifically about early age onset cancer, which I'm looking forward to our panel because issues facing those of us who were younger, under 50, at the time, the screening age was 50. I was 43, 44. and I wasn't even eligible for a colonoscopy. It was only because my doctor said, let's get a colonoscopy, that saved my life. So, with that, thank you so much. Desiree, let me hand back over to you.
Thank you, Stacy. I mean, we're all in tears of joy. I mean, you are truly an inspiration and a strength, and what an incredible journey you have been through as a survivor and a caregiver, and now helping so many patients. Your company is so lucky to have you. So thank you so much for sharing that. It's truly remarkable. So we so appreciate you being here and sharing your journey with us. And happy that it has a happy ending and you're here to help patients. So thank you. As a reminder, please add any questions for our speakers to the Q&A. We will address these during the panel portion of our program. So it's now my pleasure to introduce you to Dr. A.J. Kashinro. Hopefully I'm pronouncing that right. She completed her medical degree at New York University School of Medicine, where she stayed on for her surgical residency. She also completed the colon and rectal surgery fellowship at University of Minnesota and is currently a clinical assistant professor practicing at Cleveland Clinic Foundation in Ohio. So Dr. Kashinro specializes in the surgical treatment of colorectal cancer, inflammatory bowel disease, pelvic floor disorders, and benign disease such as diverticular disease and anorectal disorder. She utilizes minimally invasive surgical techniques, including laparoscopic and robotic assisted procedures. She is dedicated to advancing the field via research and previously completed a research fellowship at Memorial Sloan Kettering Cancer Center. Her interests lie in optimizing colorectal cancer care and addressing disparity in cancer care and outcomes. So it's my pleasure to welcome you right now, Dr. Kashinro. Thank you so much. Am I pronouncing that right?
Can you hear me? Yes, you are. Thanks, Desiree.
Thank you so much for being here. We can't wait to hear from you. Also, quite the bio there. So thank you.
All right. Thank you so much. I just wanted to say, Stacy, it was such an honor to hear your story. And even as a provider, it's very important to hear patient experience and what you went through. And thank you so much for sharing. So I'm going to start talking about as on the provider side, as the clinical aspect of early onset colorectal cancer. And as Desiree said, I'm a associate professor at Cleveland Clinic, and I'm a colorectal surgeon, and I do take care of patients with early onset colorectal cancer. I do not have any disclosure, and this is my objectives for today, just going over what is early onset colorectal cancer, diagnostic considerations we should have, and therapeutic consideration. So just some quick background about some of the numbers. Colorectal cancer is the third most common cancer and cause of cancer-related death worldwide. There has been a decline in incidence of colorectal cancer, but mostly in those over 50 years and older. And this is mostly due to screening and change in the modification in the risk factor. Similarly, there's also been a decline in the mortality in this age group. But in those younger, we starting to see increase in colorectal cancer, so about 1 to 2% increase per year. And the mortality is also increasing by 1% per year. In 2020, 12% of patients diagnosed with colorectal cancer were less than 50 years old, of which 1 in 4 had metastatic disease. So when we're talking about early onset colorectal cancer, I just wanted to reiterate, that means we're talking about patients who are less than 50 years old. And this is just data from using the SEER database, kind of showing what we're talking about. So when you look at the top of this graph, you have the patients with colon cancer, and then the bottom is rectal cancer. And this is over the last four decades or so. And you can 3 decades, sorry. And you can see that there's been an increase in the early onset incidence of colon and rectal cancer, and that's the left side of the graph. And then on the right side is those over 50, and you can see the decline. On the next slide, this is again looking at incidence on the left and mortality on the right. The very top of the graph are the early onset, the middle are of the 50 to 64-year-old, and at the bottom is 65-year-old plus. And again, on the left side, you see increase in incidence. On the right side, you see increase in mortality. which is about 1% per year in those less than 50 years old. Whereas those that are older, they're having a decline in incidence and mortality, especially in those older than 65 years old. And then finally, again, this is just a graph showing patients who are early onset have a higher likelihood of having distal disease, whereas those who are older have more localized disease. So the first question is, why is this happening? So when we talk about why, we got to look at the risk factor. You look at the inherent, genetic portion of it, and there are some patients who have hereditary risk factor from syndromes such as Lynch, FAP, which is a type of polyposis syndrome, and there's other type of polyposis syndrome. Unfortunately, this only accounts for 20%. So there's still over, a majority
Hey, Kathy, good
of
morning.
patients with early onset, majority of patients with early onset, we still don't know why this is happening. And when we look at the risk factor, we're talking about things like smoking, obesity, physical inactivity, high consumptions of processed meat, low fiber, excessive alcohol. Those are the risk factors associated with common the cancer, but there's no strong link to patients with early onset. So why is this happening? One of the more promising area of research is microbiome, which is based on your own natural body flora. But there's still a lot of research going on this. So I'm not going to get into that too much, but just there's a lot of research trying to figure out what's happening. So I'm now going to focus on the challenges, diagnostic and therapeutic. So for diagnostic challenges, so even though the age of screening has been changed to 45, those that are 45 to 49 years old are still not, enough of them are not getting screening. So only 1 in 5 are up to date. So if you look at that graph in the upper corner, you will see those from 45 to 49 years old in the middle, only 20% are up to date. So there's still a lack of education and awareness, even though the age of screening has changed. And then those less than 45 years old, routine screening is not recommended. So for those that are symptomatic, the symptoms are usually dismissed or misinterpreted. So that leads to delay in diagnosis and later stage of disease. And then in addition, more than half of the patients were early onset, wait up to a year to seek medical care. And then they are seen by an average of 3 medical providers before a diagnosis is made. So other clinical aspect to think about too is if you look at the right side of the picture, the top of it is very early onset, so that's 14 to 35 years old, and then the middle is the early onset, 35 to 49 years old, and then the bottom is average onset. Data shows that patients with early onset disease tends to present with left-sided disease, which has implication for treatment and presentation. And most commonly, if again, looking at the left side of this picture, the most common symptoms they presented with is bleeding and abdominal pain, which is kind of non-specific if you think about it. And then finally, just one of the most important points is that even though patients are presenting more advanced, there actually is no biological difference in the cancer in the early onset patient versus the average onset patient. So this kind of brings up the importance of the PCP. So in addition to making sure that the patients that are 45 to 49 years old are getting their screening, I think that it's very important that patients with some of the alarming symptoms that are not getting better, regardless of their age and family history, their symptoms should not be minimized and they should be sent for appropriate evaluation. And like Stacey just said, her PCP was very key. Even though she was 43, her PCP was very key in her getting that scope and having her diagnosis. And then just talking about the therapeutic consideration and challenges. And like I mentioned, there's no biological difference in the tumor. So patients actually have similar chemo response when treating early onset versus average onset. And the therapeutic options are the same. So I'm doing the same surgery I usually do on average patient that I'm doing on my young onset patient. So it's very important to avoid overtreatment because yes, the patients are young, so we want to be aggressive to try to treat them, but sometimes it's not helping. So we just always have to be cognizant of that. So for example, with stage 4 cancer, there tends to be providers with more aggressive approach, taking out all metastatic disease, doing more intense adjuvant chemotherapy. And sometimes there's no survival benefit, but that's why multidisciplinary discussion is very important because some patients benefit from it. So selecting the patient that would likely benefit from it and approaching with a curative intent is very key. And as I mentioned, patients are more advanced, early onset patients are more advanced and they have left-sided disease. So that has implication for the treatment. They typically will need chemoradiation, and that has a lot of sequelae and things like infertility, sexual dysfunction, bowel dysfunction, body images, things to consider in this patient population. And that's kind of where the Young Onset Cancer Center is very important. So the Young Onset Cancer Center is very important because it has helped create a centralized, make sure the patients are getting coordinated and comprehensive care, as well as individualized care. So this usually includes program coordinators who helps navigate that system with this, new overwhelming diagnosis. It's nice to have someone who helps you with that. Genetic testing, like I said, ruling out, making sure there's no evidence of a genetic component, because that will have implication for siblings, children's, and that's very important. And then fertility preservation and sexual health and psychology. At Cleveland Clinic, we have a Young Onset Cancer, and I do think most of my patients that have been inducted into that has been very helpful for them. So I'm just going to mostly focus on fertility and the psychology portion, because this is a limited time. So in terms of fertility, as I mentioned, with the chemo radiation, with the chemo, with the radiation surgery, they actually, there's a reduced fertility from treatment. However, few patients are receiving the appropriate counseling. So, and counseling does reduce long-term regret and dissatisfaction amongst survivors. So, it's very important that patients are getting routine onco-fertility consultation for all young onset patients with of childbearing age, because then they can discuss fertility preservation. And then in terms of psychological component of it, patients are often in the young onset population, they're often in the prime of their personal and professional years of productivity. So you can imagine this is a very devastating diagnosis. So, they tend to have more emotional distress and anxiety, fear of procedure, disruption of life plan, and, from work to their family life, relationship, education. There's always concern about ability to have more, have kids, or have more kids. And then there's the financial component as well. So this is where the psychologists and social workers play a very important role. So I would like to finish with some key takeaway, which is that, increasing awareness of the rising incidence of colorectal cancer in those younger than 50 years old is very important. And that also is very important for PCPs as well, so that some patients that are appropriate for screening are getting screened, and those who come with symptoms are getting worked up appropriately if it's not improved. And then again, which goes to the clinical presentation and indication for the evaluation. And then finally, the treatment is actually very similar between patients with early onset and average onset in terms of surgery, chemo, and radiation. But there are some portions that are very important, special consideration that necessitate things like a young onset cancer center, which help keeps a centralized and coordinated care, so that every different aspect of this is, addressed. And that is all I have to say. Thanks so much, and I'm looking forward to the panel. I'm going to hand back over to Desiree.
Thank you so much, Dr. Kashinro. That was so insightful, and we so appreciate your presentation. Thank you. So it's now time for our third poll question. So get ready to answer that. In your opinion, what are the most significant challenges that cancer patients under the age of 50 face? So select all that apply. That should be coming up on your screen. And you can see those, social isolation, family impact, work-related issues, financial toxicity, insurance coverage, long-term late effects of treatments, quality of life. So please vote on that. Thank you for doing our poll questions. So I am very excited to see and to hear from Samantha Hewlett. She's our next speaker. Samantha is a clinical social worker and currently works as the James Adolescent and Young Adult Social Work Navigator. She completed her master's at the University of Denver, and she has spent the past 12 years in oncology. And we're excited. We can see real quick, I'm going to give you the poll questions in a minute, but before we want to bring Samantha in. But so you've also worked with full-time young cancer patients for the past 5 years. Is that correct, Samantha? Nice to see you. So I just wanted to tell you, we're going to answer the poll question, but 79% of you guys said family impact, social isolation is 53%, 80% is work-related issues. These are the challenges that face cancer patients, right? Every single one on the screen faces cancer patients. Insurance coverage was 56%, and quality of life 65%, and long-term, effects of treatment 62%. So unfortunately, all those things affect cancer patients and have an impact. But it is now my pleasure to welcome Samantha Hewlett, and we're so excited to hear from you. And thank you for all the work that you do.
Thank you, Desiree. Hi, thank you so much for having me. My name, like Desiree mentioned, is Samantha Hewlett, and I am the young adult clinical social work navigator here at the James. And I just thought it might be helpful to go over the services we provide patients with early onset cancer here at the James. So I think this group knows the importance of providing specialized care to this population, but I will talk specifically about AYA a little bit because that's my specific role. So the NCCN defines adolescent and young adult cancer as those patients diagnosed between the ages of 15 and 39. So the James is an adult-only institution. So I see patients typically between 18 and early 40s, but we'll talk obviously about implications for those with cancer under 50 today. We know this group has unique treatment needs, and we know that specialized care, as sort of has already been mentioned today, really makes a difference for this group. Next slide, please. So what we know is that even though these challenges are unique and somewhat normal for this population because of everything they have going on at this stage of life, from managing, planning a wedding to having kids to, excelling in their careers, and then cancer comes in as a significant disruption. Even though there are normal and unique challenges, that doesn't mean we can't do anything about it. Because we know, again, sort of age-based screenings and properly trained providers really makes a difference for this group. And so here at the James, we've developed a specialized program called the AYA program for this patient population. Next slide, please. There is a referral in our medical system in IHIS called the Ambulatory Referral to Adolescent and Young Adult Care. And those patients automatically get scheduled with me, our navigator, based on their age, regardless of their disease group, which is unique because a lot of institutions really sort of focus on appropriately so disease-specific care. And so this provides also age-specific care in addition to the incredible specialized care they're getting within their disease groups. Each disease has a little bit of a different way of getting these patients to AYA. Some use the intake coordinator who goes through new patients. They enter the referral. Some physicians prefer to do it themselves. But however the referral gets entered, these patients are able to be seen for a full assessment, to be able to go through their distress, to sort of give information and resources based on their concerns, whether they're physical concerns, family concerns, emotional support concerns. And then we can provide, again, support and resources. These patients can be seen in clinic. We hold clinic 4 days a week. We actually will go see these patients in the hospital as well, because there is no bill or copay for the service. We have sort of less barriers to be able to access them as they need throughout their care and survivorship, because we know these patients really benefit from continuity of care. We have really tried to emphasize in our system that this needs to be standard of care for these patients instead of really waiting until we know they're distressed, because oftentimes, as we've heard, these patients are managing talking to kids about what's going on. They're managing figuring out how their insurance works, what leave they might have available through their employers. And so Oftentimes it's survival mode, just kind of getting to the appointments, and it's very helpful for them to not have to ask for the help and to just have it already be offered through this kind of visit. Common referrals within our system that often comes out of the assessment are referrals to genetics. There is psychosocial oncology, counseling, and medication management specific to cancer-related distress. We offer referrals to nutrition. Art and music therapy can provide sort of that expressive therapy for patients who maybe are hesitant about talk therapy or are a little nervous about what they would say. Sometimes it's easier to access some of that support through expressive means. We have a wig shop available for patients to be able to have a wig ordered and billed to their insurance, or for those patients who maybe insurance doesn't cover the option, they can apply for financial assistance. And what we know is that even though something like that might seem small, we have patients who are teachers who, say, I don't want to have to tell the kids all day long about my cancer. I just want to be able to put on the wig and go to work. And so even something like that can make a huge difference. Financial counseling, we know financial toxicity is huge for these patients, and sometimes they don't realize there may be institution-specific assistance available. And so making sure those patients know that even if their income, they might not assume they'd be eligible for support, that it's still always worth having the referral and being screened. We just heard a little bit, obviously, about the importance of oncofertility. And again, it's not just important to have the referral if they want to pursue fertility preservation, but also to limit that distress following treatment, knowing they were given a discussion about the implications. We have the Women's Integrated Sexual Health Program to help women understand potential changes that can occur should medication induce early menopause, and sort of potentially with sexual dysfunction. This isn't up there, but often also physical therapy and pelvic floor physical therapy can have huge implications for potentially pain or sexual dysfunction as well. We have integrative medicine, acupuncture, massage. There's options, obviously, for palliative care. And then I think we heard earlier, just how difficult oftentimes talking to kids is. What would I tell them? What will happen if they ask that scariest question, like, will you die, mom? Will you die, dad? And sometimes kids get really overwhelmed, and it's beneficial to have somewhere to bring them. Maybe they don't necessarily need counseling, but want some health-related information. So we've recently added Child Life to see kids of adult patients, and sometimes they're giving information on how to talk to kids about cancer, and sometimes it's really procedure specific, like mom's going to have drains in and here's what drains look like, or unfortunately, based on sort of a certain cancer, mom's going to have to, or dad's going to have an amputation, and what does that look like, and offering kids the ability to play and be prepped in addition to whatever their parents are discussing, just kind of takes the pressure off that the parents have to have all the answers at a really overwhelming time. It gives them very specific support. In the hospital as well, Child Life has been a huge resource in sort of legacy building for patients with advanced cancer and making sure their kids are included, even at times that might otherwise feel too overwhelming to have them at bedside. Next slide. And then that's sort of the clinical intervention, the personalized psychosocial support. But then we also know social isolation is a huge challenge for these patients that maybe are navigating different kinds of stressors compared to their peer groups. And so really offering opportunities for peer support has made a huge difference. We've really tried to listen to the patients. Again, sort of getting that voice is hugely important to making sure our resources and programs are reflecting their needs. I will say oftentimes we think support groups are the way to go, but after years of trying, sort of support groups did not necessarily work super well for this group, and we switched them a little bit to monthly meetups, meaning there's still an opportunity to come and connect, but that there's a sort of focused activity, whether it's trivia night or a cooking class or a hike with physical therapy. These patients are really wanting to do something that they might otherwise want to do, but just having a chance to connect authentically at the event. And we know that it's making a difference because each month these programs have been full, oftentimes with wait lists. And it's really allowing the patients to, and caregivers, right? Because patients and caregivers are included, to have something to do together, and also a way to just build community. We have a website where we keep those events updated. There's a blog where patients can sort of share their voice, and a patient panel. Oftentimes at diagnosis, patients want to hear from other patients, but maybe aren't ready yet to go to an event or aren't feeling well. And so they can go online and sort of watch a video where other patients speak about what they wish they would have known at diagnosis, or sort of at survivorship. When we know sometimes distress increases, we really try and provide voices across the continuum so patients could go online and identify with a part of a story. And that's just some positive participation feedback, which again, just listening to those patients along the way has made all the difference in providing these programs. Next slide. Thank you so much, and we'll look forward to talking more during the panel.
Thank you so much, Samantha, and for all that great information, all that you're doing for young adults and adolescents at the James. So thank you. Our final speaker will be Dr. Sarah Fogarty. Dr. Fogarty earned her Doctor of Osteopathic degree from the University of New England College of Osteopathic Medicine in Maine. She completed general surgery residency at Sinai Hospital of Baltimore, where she served as chief resident from 2012 to 2013. And she also completed a fellowship in breast surgical oncology at Women and Infants Hospital, Brown University in Providence, Rhode Island, graduating in 2014. So she is a board certified in general surgery. She also specializes in all aspects of breast disease, both benign and malignant. And she has a special interest in post-mastectomy pain using trigger point injection techniques taught during her osteopathic training. And she is also interested in fertility preservation and premenopausal cancer. So she works closely with community organizations such as the American Cancer Society, Hopewell, Almond Cancer Fund for young adults, and many others to educate the public regarding breast cancer screening, the importance of that, the risk factors, and latest advances in breast cancer treatment. So she has been named Baltimore Magazine Top Doctors issue annually since 2020. Congratulations for that. And she currently is appointed to the Executive Council of the Maryland State Chapter of the American Cancer Society, serving as cancer liaison physician. Welcome, Dr. Fogarty. Thank you so much for joining us and for all that you do.
Thank you so much. Can you guys hear me okay and see me?
Yes, we can hear you.
Okay, great.
Glad to see you. Oh, we just have to have you turn. Nope, right now we just see Sam's camera. So hopefully we'll see you soon, Dr. Fogarty. But we can definitely hear you if you want to.
Okay, good. I'll start. I don't know why.
There, do you want to turn on your camera?
It's on, I thought. Hold on.
If not, you can start.
Well,
does anyone else? There we go. We
good.
see.
Great.
All right.
Great. Oh, perfect. Okay, good. Good morning. Thank you so much for having me. I was asked to talk about fertility preservation, which is definitely a part of my practice, but I am not a fertility specialist. So obviously I'll try to do my best to answer questions from the panel. But this is something that comes up in my practice every day, especially with the younger patient population we've been seeing. So next slide. My objectives for today are just to talk about the understanding the need for fertility preservation in cancer patients, type of cancer treatments and how it can affect fertility, options for preservation, and of course, costs. Next slide. I have no disclosures. So of course, the current issue is younger age of cancer diagnosis and older age of firstborn, which has been trending for the last, 20, 30 years. This next year in 2024, I believe the American Cancer Society expects more than 2 million new cases of cancer to diagnose, which is the most ever in a year. So the increase in overall early onset cancer, that age of 18 to 49 years, incidence has been increasing steadily 1 to 2% a year. Just a quick, we can go to the next slide. Just number of cancer cases in 2023. Of course, breast and prostate are normally the most common cancer, but not the most likely cause of death. Lung cancer continues to be the highest cause of death of cancer in the United States. This is from 2023 data. Next slide. So younger age of diagnosis, this is something that's been looked at really for the last 20 years or so. The incidence has been rising, really substantial increased rates in GI cancers. Breast cancer also has the highest number of incident cases, whereas GI cases has the fastest growing incident rate. Everyone's been investigating, why is this happening? Is it sleep deprivation, alcohol consumption, altered microbiome? There's a lot of different reasons for why this is happening. Next slide. Just the most common leading types of cancer in young adults: thyroid, breast, colon, cervix, which has been decreasing steadily with the HPV vaccines. Next slide, please. Again, colorectal, as we heard about, a lot of new cases in people under 50. Breast cancer, they're expecting about 310,000 new cases in 2024. And these rates have been steadily increasing since the mid-2000s by about 0.6% per year. Melanoma rates have increased dramatically with the use of tanning beds, which are not as in vogue now in the patient group of 15 to 30-year-olds. Next slide. Again, cancers by number. If you look at that first column, I know this is a busy slide, but that 0 to 49 age group, looking at all sites of cancer, you can see 1 in 29 and 1 in 17 in male and female. So that's a significant number of cancers in this young age group. Next slide. So looking at advanced maternal age, so talking about people getting diagnosed with cancer earlier, and then of course having children later. In the United States, the average age of having your firstborn is 27.3 years. This has increased from 2011. The average age was 25.6. Women over 35, the rate of having their firstborn is really steadily increasing, up 23% from 20 years ago. And of course, fertility declines as you get older, after age 32, and very dramatically after age 37. The rates of assisted reproductive technology have doubled in the last decade because of this phenomenon. Next slide. The lean in movement, of course, and this was, a little while ago, but really the age of, women focusing more on career and families than families, and starting to have their children later in life. If you can go to the next slide. So just to talk a little bit about reproduction and what happens. Of course, women have a limited number of oocytes in their lifetime. Obviously, the highest number is present before birth, about 7 million oocytes. And this, over your lifetime, you have approximately 400 to 500 mature oocytes that are released into the fallopian tubes. Obviously, if those oocytes that are stored that are immature are damaged by cancer treatment, then your fertility could be at risk. Go to the next slide. In males, sperm production is the primary requirement, of course, for male fertility. Sperm development and develop and mature in the seminiferous tubules located in the testicles, which sits in the scrotum. There's a constant production and development of sperm, making them a prime target for chemotherapy, as chemotherapy does affect rapidly dividing cells. If you can go to the next slide. So chemotherapy in women, how does that affect fertility? Chemotherapy works by killing rapidly dividing cells. So cancers that are aggressive and fast growing, chemotherapy really works for. So these cells lining the GI tract, your hair follicles, and germ cells, which include reproductive cells, are really susceptible to chemotherapy effects. And so in women, it's hard to know, how can we predict infertility in each patient? It's really impossible to determine definitively. It really can depend on multiple factors like the drugs received, and a lot of different cancer treatments require combinations of chemotherapy, which can be more toxic for fertility. How long do patients get drugs for? A lot of our stage 4 patients sometimes take oral chemotherapy forever. They can take holidays, but it's a constant treatment plan that they're on to treat the disease and keep it at bay. And also, of course, the age when initiation of chemotherapy and how large is the follicle pool. Women that are potentially still premenopausal, but in their early 40s, that follicle pool is much more depleted than in their 20s. So that can really affect fertility. Chemotherapy in men, same idea. So azospermia, meaning no sperm, or oligospermia, which is a low sperm count, usually can be temporary after chemotherapy. You can see these counts recovering in months to as long as up to 4 years after treatment. Also, chemotherapy can affect the genetic makeup and DNA of the sperm, which can cause issues with development of the fetus. So men have been typically counseled to not father a child for about 2 years after therapy. Next. So these are just some very common chemotherapies we use for different cancers. The alkylating agents we know are at a higher risk of causing fertility issues. Next slide. Hormone therapy. So for my patients, of course, tamoxifen is a very common drug that we use to decrease risk of recurrence of estrogen positive breast cancers. This can temporarily stop or alter menstruation. It is possible for women to get pregnant while on this drug, and this is a teratogen where you really cannot get pregnant while taking this. It can harm the fetus. So we always require 2 forms of birth control in women that are premenopausal getting this medication. It can also be difficult to understand if women are becoming postmenopausal. It can alter levels of estradiol and FSH levels, making it hard to assess if women, what their ovarian function is. Are they still, are premenstrual? Are they still ovulating? Is that still a possibility once the tamoxifen dose is stopped? Next slide. Radiation therapy, another therapy we use very commonly that can affect fertility, really dependent on where radiation is being targeted. Obviously, abdomen and pelvis in women, it can damage the uterus, can damage the cervix. Absolutely no radiation is allowed to be given during pregnancy, so that can affect recommendations for treatment. In young women with breast cancer who are pregnant, breast conservation therapy, where we do lumpectomies if they are going to be pregnant and that radiation dose can't be given in a timely manner to actually reduce risk of recurrence, then that's really not an option for them. So that can affect our surgical recommendations. Again, age of patient when they're getting radiation is important. And total body irradiation, which is something that is used for stem cell and bone marrow transplant. Over 85 to 90% of women can have permanent ovarian failure. Next slide. In men, again, depends on where the dose is. Again, pelvic, are you shielding the testicles? Are you able to? Is it testicular cancer you're treating? Prostate cancer you're treating? Again, total body irradiation, you can have an 80% chance of permanent fertility loss. Brain radiation in men can affect the pituitary gland, affecting sperm production as well. Next slide. So talking about preservation of fertility in women, this is, in the last 30 years has really become much more mainstream. There is egg or embryo freezing or cryopreservation, ovarian transposition, ovarian tissue freezing, and then radical trachelectomy, which is actually preserving the uterus in cervical cancers where they remove the cervix. And this is really only indicated in early stage cervical cancer. So these are all options where we're allowed to or able to talk about preservation and what can we offer women depending on their age and what stage they are in their fertility and if they desire pregnancy. It's really something that as a doctor taking care of patients that are young with cancer and any specialty taking care of these patients, it's really on the physicians to bring this up as a potential option. Decades ago, this was never even discussed. It was really, let's save their life. And now that survivorship rates are so much higher, especially in breast cancer, we really have to focus on, quality of life. And is this something that patients want to pursue? I have plenty of women in their 20s that get diagnosed, 30s and that get diagnosed that haven't even thought about having children. I have women in their mid 40s, late 40s that still desire children and have not had them or want more children. So this is something I bring up in every woman that is potentially interested in more children or having children. Next slide. Again, in males, so sperm banking, cryopreservation, this is something that we would do prior to starting any treatment. Same in women. For cryopreservation, we always want to talk about it and initiate it before starting any treatment. And the way they can do fertility preservation now, the cycles for IVF and storing and banking eggs or embryos, that can be very quickly done within 2 to 3 weeks. So we're not really holding up treatment. In men, same thing. We want to collect prior to starting treatment, and multiple samples are best. In women, if we have time for 2 cycles, that can really be beneficial for their banking, how many eggs or embryos they can save. Testicular aspiration also is an option if the sperm counts are too low. Next slide. So ASCO guidelines for fertility preservation. Again, this guideline was first produced, I think, in 2013, and in 2018 they had an update. Really no major changes on reviews of about 61 new articles from 2013 to 2017. So they didn't really change these guidelines, but this is something that all cancer physicians should be looking at, and any physician taking care of a patient who could potentially benefit from fertility preservation before starting their cancer care. Next slide. Costs. This is always a huge issue. And I'm lucky, I'm in the state of Maryland, and we have a lot of laws in place and help with insurance for patients with cancer. Sperm banking, collection, process, and freezing, a cheaper process than for women with eggs and embryo freezing. There are yearly storage rates for all of these for all patients, and there's costs for thawing and implanting. Usually storage rates are not covered by insurance. And of course, the IVF cycles of getting eggs and embryos can be very costly. I mean, 11 to 15,000, maybe even low, up to $20,000 for these cycles. That's a huge stress for patients. When we send women for fertility discussion in our patients before treatment, this is a huge part of their counseling is financial aid and costs. So this is something that, can be a lot of stress for patients, and is something that's really important to bring up with them. Next slide. So currently in 21 states, there are laws requiring insurance coverage for infertility treatment. This is not just for cancer patients, but in general. So it's only 21 states, but better than it used to be. For Maryland, the state has had updates in their coverage, and actually it's much easier to get coverage. There used to be a law requiring at least 2 years of trying before you were able to get insurance to cover. Now it's not required to be that long. And also you're not required to be married, which in some states you are, and that can be a big issue for a lot of patients. In Maryland, a state law mandates insurance coverage any iatrogenic infertility, which of course can come from cancer treatments of anyone in childbearing age, that IVF treatments are covered. The annual freezing storage fees in most cases are not covered. Next slide. And then talking to women about this, the biggest question I get asked, of course, is they've been diagnosed with breast cancer. We're talking about their treatment. We're talking about fertility preservation before that treatment starts. And they get very concerned about, well, I already have breast cancer. What's my risk of, recurrence doing IVF? Is that going to increase my risk? Should I not do this, even though I'm only 30 and I've never had children and really want that? So this was a large study out of the Netherlands that came out, I think in 2016, it was published in JAMA. This looked at over 25,000 women, 19,000 of which started IVF between the years of 1983 and 1995, and they've been followed for 20 plus years now. And it showed that there was no statistical difference in increased long-term risk of breast cancer among these patients. So women ask me this all the time when they're coming in for either high-risk assessments or they've been diagnosed with breast cancer, if we're talking about giving them tamoxifen to reduce their risk of getting a breast cancer, or talking about chemotherapy because they have breast cancer. We bring this up constantly as, there's no statistical significance that it's going to worsen your outcome by doing this. Next slide. So just a lot of questions that we get asked. Can you get pregnant after having chemo? Can you get pregnant while having chemo? Can radiation make you infertile? And can you have chemotherapy during pregnancy? Next slide. So yes, you can get pregnant after having chemotherapy. It really depends on the age of treatment and types of drugs used. Can you get pregnant while having chemotherapy? Yes, you can. And so that's also something we require 2 forms of birth control to make sure that does not happen. Radiation, as we talked about, especially total body irradiation, can make you infertile. And chemotherapy during pregnancy, yes, that's absolutely a possibility. In second trimester patients, we have several of these patients, unfortunately, that this happens, and we are able to safely give chemotherapy when they're pregnant. So those are just a lot of common questions we get asked. So in summary, fertility preservation is really a big issue in cancer patients because of earlier age of diagnoses and older age of having first children. Chemotherapy and radiation therapy can result in permanent infertility, and it's very hard to predict in which patients that can happen. Many options for fertility preservation. Really, cryopreservation is so mainstream these days and is very simple. Our patients can get in for a consultation the day we call or the day after. They can do a 2 to 3 week cycle and then start their chemotherapy for their breast cancer. And they do very well with that. So really it's on the physicians, to really bring this up with patients who of course are thinking about, their cancer diagnosis and the worst case scenario. And we want to make sure they understand these options. And costs can be high, but there are a lot of programs to cover, and the state of Maryland does have some coverage is mandated, which is great for us. So that's it. Next slide. Any questions? Appreciate you all having me. Thank you so much.
Thank you so much, Dr. Fogarty. We so appreciate you and that important information that you shared with us. So I know there will be questions for you in our panel discussion. So it is my pleasure to introduce our panel moderator, Dr. Doug Flora. Dr. Flora is the Executive Medical Director of Oncology Services and the Robert and Del Ann. Is it Saith? I'm not sure if I'm pronouncing it right.
Sathi.
Is it? How is it? How do you pronounce it? Sathi, thank you for that. Sathi Endowed Chair in Oncology at the St. Elizabeth Healthcare Cancer Center. Dr. Flora graduated from the Ohio State University College of Medicine with a distinguished career spanning over 2 decades. He is a steadfast advocate for whole person care and medical innovation. His leadership and vision have led to cutting-edge technology and treatment protocols and improved patient outcomes. Dr. Flora's dedication extends beyond clinical practice as the editor-in-chief for the pioneering peer-reviewed research journal in AI Precision Oncology. He plays a pivotal role in medical education and research, nurturing the next generation of healthcare leaders. And his perspective as editor-in-chief is enriched by personal experience as a practicing oncologist, senior healthcare executive, and most importantly, a cancer survivor. So we are so excited to welcome you. Dr. Flora is also a board member of the American Cancer Society, as vice chair of the Ohio, Northern Kentucky, and West Virginia region here. And so we are so appreciative to have you as our panel moderator and to host this panel discussion. And welcome. Thank you so much.
Thanks, Desiree. Great talks, everybody. I'm taking notes here for my own system, and I'm ready to start a young cancer patient forum and program in my own center. So we've got a lot to cover. I've got pages and pages of questions. For those of you that are viewing, please do use the question and answer function. I'll try and get to these live. I've got it open on my second screen and specify, if you can, to whom you'd like these questions directed after hearing what they've had to share with you. The only objection I have so far is that I'm a 2-time cancer patient and I'm 52, and I still think that should qualify as a young cancer patient, but we can talk about that offline afterwards. So why don't we start with some of the questions that have rolled in already. I will tell you, I'm a medical oncologist here just outside of Cincinnati. I've spent most of my life taking care of breast cancer patients, many of whom are young, several of whom have been pregnant, and all of whom have existential dread. And I think you guys have all really understood that and articulated that well. I may start with Sam because our patient and family advisory committee here taught me a lot. I think of myself as a very empathetic physician, and we were talking about the things that we needed to produce most as a cancer center and what sorts of things that we were missing. And in our survey instruments, and when they talked to us, the number one question they said they were grappling with was, how do I tell my kid I have cancer? And that was patient centric to me. Talk about whole person care. I'm all about chemo and CAT scans and tumor markers and, genetics. Maybe Sam, can you talk about some of the things that come out of those meet and greets and the things that you're doing for these younger people, because they have a completely different list of concerns than a 79-year-old guy with prostate cancer.
Yes, thank you for that question. And I know Stacy spoke about this earlier. I meet with patients every day that sort of say, I couldn't even hear what I needed to do because all I was thinking about was how this was going to impact my kids or if it was going to impact my kids. And so giving them language and also sort of being able to provide research that shows like they can actually adjust well instead of feeling like this is only going to be bad. And giving them books to read. There is actually a national nonprofit called the Bright Spot Network that will send these families free books and free art activities to do at home. And they'll do groups online for the patient in active treatment, the caregiver parenting young kids. The Pickles Group is another national nonprofit that will provide sort of free peer-to-peer support for the actual kids going through having a parent impacted. There's Camp Kesem. But we really do talk to patients to say, like, research supports you giving them the information that's developmentally appropriate. And then just allowing them to be able to ask questions. But I think you're exactly right. Just giving them the tools to know that there is support will oftentimes sort of put their minds at ease so that they can actually get ready to hear about their treatment instead of being so focused, appropriately so, on how this is going to impact their kids.
Yeah, fantastic. And I've done a few, we call it Camp Joy down here through Cancer Family Care, where we sit on the grass at a camp where kids have done archery and canoeing with other children of young cancer patients. And it reaches that next generation too. Why did you knock out my mom's hair? Those sorts of things, because they don't have any context at 8 or 10. And those are the things my moms were taking most of their time dealing with, is how do I have these conversations in an age appropriate fashion. So I love that you've wrapped them in the surround sound of your program. So maybe Stacy, you and I had a very similar experience. I was 48 and had a 10-centimeter kidney cancer resected. And of course, the existential dread hits. And it certainly is a mission moment for me as a cancer doctor and as a volunteer for the American Cancer Society. When you had your first thoughts, and obviously the dread and waking up in anesthesia, 11-centimeter tumor, say, how long did it take after the news sunk in before you were able to shift gears as a patient? As a doctor, I'm trying to figure out, and I think probably my partners here, the other physicians, how much is too much for us to levy onto you that first week or two, because there's just shock and awe, and most people just shut down and stop listening. When did you get your game face? How long did it take you? 2 weeks, 2 months, 2 years? Have you not found it yet? It sure seems like you have. Because mine, I went dark as an oncologist for about a month. I'm just very curious how you dealt with that particular part as a young cancer patient.
Yeah. Well, first of all, Dr. Flora, fist bump, fellow survivor, to you. And thank you for everything you do. Yeah, especially in my advocacy work, this is what I tell patients, that the worst time is between getting the diagnosis and getting into treatment, because you're in that spot of, I know I have something really bad going on. I have cancer. I'm trying to process it. And I'm not able to do anything about it. Like, I have this thing growing inside of me, but I'm not. So that, like, I always tell them, I'm like, just try to get through this time. Keep yourself busy, keep yourself occupied until you have your plan, right? Because then you have your plan and you go into fight mode. But I remember very vividly, this is my 10-year cancerversary this year, big year. And I remember very vividly, just thinking for the first couple days, I am going to die. I am going to die. What are my kids going to do? 8 and 10, a special needs child. That's why I knew, like, I could not die. Like, who would take care of Emmett? And I remember when my son asked me if I was going to, my 10-year-old asked me if I was going to die. And I looked in the other room, and my husband was changing Emmett's diaper at the time. And I was just like, I cannot die. There's absolutely no way. So it was, yeah, to your point, it was definitely at least a week. I remember my husband and I went out for a walk on a trail, and I was just trying, right after I got the news, and I was trying to process it, like, what is going on? Because prior to this, other than having like family members with cancer, I really didn't have any experience with cancer. I didn't really, like anybody else, I didn't know what metastatic cancer was. I didn't know what staging was. I didn't know any of that. And I just was like trying to wrap my brain around it, like that this was happening to me. And especially, going back to, if I may say, Dr. K, because I don't want to, but your presentation, you look at that list, and I was the healthiest person ever. I was an athlete, non-smoker, didn't, had great eating habits and everything. So it's like, why did this happen to me? Like, what did I do wrong in my life, And as you heard, especially with early age onset, which I stay in touch with the data and the research as well, and we don't know why. We're seeing this alarming trend, this trend line like this in colon cancer. We do not know why. So that's frustrating. But anyhow, circling all the way back, yeah, it was a good week too, but it was when I got my plan, when I got into chemo, and that I knew that I could do something to fight back, is when I got my game face on, to your point, Dr. Flora. Like, that is when I was like, all right, we're going to give it all we got. And I pursued a ton of, I met with an integrative oncologist. I did integrative oncology techniques. I did yoga. I did everything. I did the yoga. I did the Reiki. I changed my diet. I did everything. And I just said to myself, if I'm going down, I'm going down, giving it all I got. I'm not going to leave anything on the table. So, yeah.
Awesome. Well, you should know, for the physicians on here, we feel exactly the same. And it's not that we don't try just as hard in that 79-year-old guy with prostate cancer, but certainly I took care of a lot of single moms in their 30s. And they said, I don't care if you have to light me on fire. I have to be at the school bus at 2. It doesn't matter what you do to me. I don't even care. And we've had the other side. I've had a couple of patients with significant special needs where mom was a sole caretaker, and the same thing. We could not do a bone marrow transplant for her mantle cell lymphoma because she had a 30-year-old kid at home who needed full-time care. And it really does enter the discussions for us as providers. We're trying to calibrate that as we're choosing our levels of aggression. Maybe that's a good transition to the medical side. So Adratu, the questions about why the rise. We're seeing this, we know it's real. I know that it's not well substantiated. We've talked about the red meats and the fiber, the changes in the diet. I think it's interesting because we're seeing this starting to affect productive members of society, not retirees, and it's getting a lot of attention. Not enough yet. How are you guys working to expand the reach of screening and prevention, early detection, gene screenings, and germline mutations and pathogenic genes, to try and get that broader reach, to get them in that earliest phase, the faintest footsteps of the cancer, before maybe they need to see me as a medical oncologist? We'd rather it's just Sarah taking care of them and not a medical oncologist.
Mm-hmm. Yep.
Yeah. Thank you very much, Dr. Flora. But yeah, in terms of the actual the screening, again, kind of trying to get the 45-year-olds, 49-year-old, very important. So anytime I see a patient in my office, if they come to see me for fissure, for hemorrhoids, and they're 45, 49, I'm like, you need a screening. You need a screening. So even though they see me for something else, I always try to talk to them about that. So because that's an opportunity to make sure they get screened. And if they're with family members, I ask them, have you gotten screened yet? So just doing that awareness, that education. And then in terms of the younger ones that are not at the age of screening, I have a lower threshold to do a scope if they have symptoms that are not resolving. So if I see someone for rectal bleeding and I do an exam, I see hemorrhoids, I give them the treatment for that. I have them come back in a few weeks. And if it's not getting better, we would need to do something else. So I think from a clinical aspect of that, I'm a little more, aware of this rise and just being thorough with my diagnosis and education. In terms of the research itself, I mean, a lot of people are doing a lot of work on this, and the microbiome data looks exciting, but we still don't know what it means. We're starting to see a signature of microbiomes that are linked with early onset cancer, but which is the chicken, which is the egg? Is it the cancer creating this microenvironment, or is the microenvironment creating this tumor? So we don't know. And we also don't know what's creating this microenvironment, because a lot of people in younger generations are more healthier. more physically active. And it's like, why are we getting this? So I think there's still a lot of work to be done for the research. We are way, we still far away from the figuring out what's going on there. But I think at least from a clinical standpoint, catching this at an earlier stage, I think should be our goal, And like you said, especially before we get to a point of advanced disease having to need medical oncology. If we can begin patients at the stage of polyps, localized disease, I think even that would be a win.
I
Sarah?
think for breast cancer, just for screening, with COVID, when mammogram screening, everything was shut down. We really, at my hospital center and with our radiology group, have made a big push to try to get everyone back on their annual screening. There's so many different screening guidelines too for breast, which is super confusing for a lot of patients. We try to do a lot of education for primary care and OBGYN. About what, the American Society of Breast Surgeons through the American College of Surgeons, what we recommend, which is yearly screening starting at 40, the US Task Force, different guidelines. In Europe, totally different guidelines. So it can be very confusing for patients and for the physicians taking care of them. So we really try to, we've done a lot of like community outreach with our radiology group to get people to sign up for their screening mammograms. We have a high risk breast cancer clinic. So patients that have any family history, we try to, recommend to their primary care's GYNs, hey, they should come in for a formal risk assessment. Should they start screening mammograms at 35? Should we be doing MRIs in between these mammograms? So we really, the screening, again, you catch it earlier, you see it earlier, it's usually easier to treat. And so that's what we're really trying to do. And also using tamoxifen as risk reduction is really one of the best things we can do. And so of course we always want to prevent, not just treat disease. And I think that's something that, there's side effects to it, there's risks to it, but a lot of doctors are shy away from saying, oh, you're only 41, maybe you shouldn't take it. Well, maybe you should. If you're done having children, maybe it's a good idea to really reduce your risk because you're at high risk because of family history. So those are just things that we've really been trying to focus on, especially in the last few years with the delays in screening that happened. So,
Amen.
yeah,
I think we're starting to get back to original levels, but it's been a slow grind. And we're probably
it's hard.
just for breast and colon, we may lose another 10,000 people that we haven't yet lost because
Right.
of the stage migration that happened during the virus. Yeah, one of the things that you guys touched on both medically, I have seen hundreds of patients over my 20-year career that presented with warning signs. You look back and they had iron deficiency anemia or microcytic anemia 9 years prior, and it was ascribed to their menses. Or for colorectal surgeons, how many patients have you received that were treated for hemorrhoids for 2 years to find it was an anal cancer or a low rectal cancer? How do we get the words out to the other providers? I mean, I'm big in advocacy now. I'm 52. I'm kind of in that second half of my career where I'm just shouting from the ramparts everywhere I can. Part of the reason we're all involved here in volunteering our time with the American Cancer Society is it's a great forum. We try to get to patients and they're going to be resistant. We try and get to their wives actually, because that's who makes the medical appointments. How about the primary care doctors who are still not fully aware of this stuff and not fully providing recommendations for the 45-year-olds or say the young Black men with prostate cancer family histories, et cetera?
Yeah, I mean, the biggest thing is always education and awareness. So having conferences like this, sending material to the office, like hand this out to your patients, I think is very key. And even communicating with the PCP, like even if I only get to talk to 5 or 6 PCP by taking care of the patient and saying, oh, okay, I'm happy to see this patient. You think it's hemorrhoids? Send them to me. I'll take a look at them and make sure. And, even just doing things like that, even if I have to see 40 patients with hemorrhoids and only one of them has cancer, to me, that's still worth it than, dismissing the symptoms. So I always tell the PCP, I'm happy to see the patient, send them to me. It's a 20-minute visit. And this could, save someone's life. So I think just having a relationship with the local PCPs and letting them know you're happy to see patient, because sometimes they don't want to overburden the specialist, right? But I'm happy to see them. And then, like I said, education awareness, making sure that we send education of material to their offices so they can give out to patients. Because sometimes they don't have time to also go over some of this, but even if there's materials they can give to the patient, I think that's very important.
I think that's absolutely right. I mean, I try to make myself as available, like our center as available as we can. And a lot of the docs within my system know they can just shoot a message and say, hey, is this a BI-RADS 3 okay? And I'm like, just bring them over, like just send them over. It's just easier for me to go through the whole thing, make sure we're not missing anything. So I think that relationship is super important to have with your system, and to get out there and tell people you're happy to see and talk to any patients. I have so many patients with, my grandmother had breast cancer. I'm worried about breast cancer, and their risk really isn't elevated, but it's good for them to know that. And if it is, then it's really important to change their screening guidelines. So I think that's a huge part of being a specialist in a cancer, in a cancer center. You really have to be in touch with your primaries and your OBGYNs, really to know, like, to help them get patients seen and evaluated.
How about Stacy on the global advocacy front? I think your story is compelling. I think everyone in your social circle probably understands the importance of this, and I think you and I both try to be advocates out there in a larger circle, because you just can't present with 11-centimeter tumors anymore, right? Not for screenable cancers.
Yeah.
Talk to me about your how you've made this adjustment. You're still very, very busy professionally. Advocacy doesn't pay very well. I don't know if you've noticed that, but the hourly wage is still set at zero. Where does your fuel come from, and where have you found that to be most rewarding to get other people on this call to maybe find those extra hours to try and get the word out like you have?
Yeah. So much to say, so much to say. Advocacy is a mission. I posted on LinkedIn about this. Advocacy is a calling. It's not, you're not in it for the money. You're not doing it for any fame, fortune, and glory. I mean, for me, I'm supposed to be dead, right? Statistically, I'm supposed to be dead. 8% chance of surviving 5 years. And all I wanted to do was make it to 50 and see my older son graduate high school. That, when I was diagnosed, those were my North Stars, right? 50 and see Griffin graduate high school, which I did. And so because I'm supposed to be dead by, all accounts, the least I can do is give back, right? I mean, and especially, with my story and my background, like, it's no coincidence that I had 25 years in healthcare, 2 master's degrees, came through, being a caregiver, being a patient. I mean, Luke, this is your destiny. I mean, this is what I was meant to do. I am in my dream job. I'm in a position where I can make an effect globally, and have a platform to improve people's lives, which I am incredibly honored and humbled to do. And if I can be the voice of thousands in need, I am absolutely going to do it. I mean, the fact that I have, this knowledge, everybody, you talk to everybody and they're like, it's, white. I have, 10 physicians that cared for me. I'm a multi-person job, but, white coat syndrome is alive and well. The general public is very intimidated to speak to physicians and very intimidated to advocate for themselves. So if I can give them that language, if I can bridge that gap, you better believe I'm going to do it. And, I'm going to be out here, fighting, for the unseen and the unheard to get the tools they need. I always say in my keynotes and whatnot, and you can tell I'm getting a little emotional, everybody should have the same chance I had to beat cancer. Everybody, no matter your zip code, where you're coming from, where you are. I'm white and privileged. I get it. I had 2 master's degrees. I knew what to say. I knew what to do. I had the financial resources. But what does everybody else do? And that's who we need to get to. And I know everybody on this call feels the same way by listening to you. That's who we're here for, and I'm so encouraged by our physicians here on the call, because what I hear every day are the patients that are dismissed, the patients that are like, you're too young to have colon cancer. Oh, it's probably this. Oh, it's probably that. Oh, it's probably, and they just ignore it and they dismiss them. So taking this more seriously, and I think another element, and then I'll shut up, is normalizing the conversation. I mean, colorectal cancer has an enormous stigma attached to it. And the media is not helping by talking about colonoscopies as, oh, it's a colonoscopy. I hate that. But I would much rather have a colonoscopy than 55 chemos, radiation, and 2 surgeries. Okay. So don't even give me that nonsense. And, you know, if anybody's out there and you are scared to go for a colonoscopy or do the prep or all of these myths and whatnot, call me personally. I will walk you through it. I will talk you through it. And believe me, nobody wants to go through what I went through if you can avoid it.
Yeah, exactly. I had a patient yesterday tell me that I've been on her for a colonoscopy for 2 years. She has a germline mutation, and she came back afterward, found one benign polyp, but she said, yeah, I dreaded this thing for 15 years and it was a piece of cake. And
Yeah.
she's now telling all her friends. I think it's been overstated. And if you're not ready for colonoscopy, I think our system has sent out multiple tranches of 20,000 Cologuard to the people in our system who have not yet provided this. And that goes to one of the screening guidelines questions. I'll get to that in a minute, Alex. But for Sam, as every speaker stated, multidisciplinary care for these AYA patients is key. There's a great need for social work team to assistance. And do you see a role for APPs to help facilitate some of these early referrals to psychosocial support, early detection clinics, fertility? It's obviously one of our best workforces right now. And it seems like we're making a lot of nurse practitioners who are interested in prevention, screening, and advocacy.
I think absolutely. I will say that as we've sort of developed our program here at the James, we went to each disease group and said, how is this going to work for you? Because everybody has a different process. Like, we wish it could just be this automatic thing that everyone has access to. But when we started to look at utilization, there were certain groups that were, you know, utilizing it on every patient, and other where there were barriers. Now, patients enter the system differently, right? Some went in for one surgery, were called with pathology, and then all of a sudden have a diagnosis. Others come in sort of in our breast world, like very specifically through our intake coordinator. So I think absolutely there's a role for APPs, but I do think it helps to sort of sit down with these sort of key stakeholders in each disease line to say, what is your process when a new patient comes in? When is the appropriate time to get the referral so that we are not missing these patients? Because something we found was some patients were not getting their appointments because they didn't have childcare, and so they didn't come. Well, maybe if we would have reached them sooner to be able to give them resources, it could have increased their compliance to get to the appointment, and then they wouldn't have been as late stage, So I think absolutely there is a role for APPs, but I think sort of sitting down with the key stakeholders in disease groups to say what will work in your line will help access improve greatly as well, or we've found that here.
Great. Maybe the next question, I'll come back to you, Ajaratu. And I should clarify, I mentioned Cologuard. We don't like to talk about branded things. In my disclosures, it says Exact Sciences. I've never actually worked for Exact Sciences. I don't know how that got on my disclosure form. Big fan. We order a lot of them, but that's not a real disclosure for me. So I can mention that without being related to them. Question on here, screening guidelines have changed. It seems insurance companies haven't kept up with coverage for the younger ages. How can we fight that? Maybe can you walk this mixed audience through how things get approved in the first place and why different groups maybe don't agree on some of these things? We know there's a huge difference between what we will recommend at the American Cancer Society and what the USPSTF will recommend, which generally drives things like what gets paid for by Medicare and payers. So I think there's a disconnect for most people who aren't medical. Why aren't we just doing mammograms at 22? Why aren't we doing full body CT scans today? And we know about the downstream harm that we might cause by overscreening. Can you talk a little bit about the process, about what makes a good screening test and how do we get these things approved in the first place? And why isn't everything freely available to everybody?
Well, I mean, that's a very good question and I think very hard to answer all of that. But the screening recommendations, so why are they what they are for breast anyway? And that's what I can speak to most. When we talk about mammograms, these are x-rays. Women who are premenopausal have very dense tissue. That's normal, and mammograms can't see very much. So the idea of doing mammograms on 20-year-olds, it's not really going to yield much information. And so when I think about like our highest risk patients, our BRCA carriers who we start doing screening on at 25, that's with MRI. And that I've had issue getting that covered. I mean, I've done peer-to-peers, I'm sure as a medical oncologist, you're going to have a lot more issues with authorizations and drugs than I have to deal with. But I do a lot of insurance peer-to-peers about imaging. And most everything isn't an issue, but the MRIs can be. They're expensive studies. But when we have gene carriers, it's very clear, like that is an absolute NCCN guideline recommended screening tool. We would never start mammograms before 30, even in our bracket carriers, because the yield's very low. And so I do try to explain that to patients when they're asking. Again, my cancer diagnoses, my early stage 1As, you know, that have a sub-centimeter tumor that are strongly estrogen positive, we're not PET scanning those patients. That's not guidelines. And people want that a lot. And so I do try to discuss with them, you know, there's no yield here. It's going to be negative. It's barely going to pick up that tumor in your breast that we saw on your mammogram. It's not going to show us a cell that's, you know, in your body. Nothing does at this point. And I think that's where the lab work will get so interesting in the future, looking at, can we screen for these solid tumors with blood tests? And that will be very great to have if it ever comes through. But I think the insurance coverage, I mean, you know, I'm not going to claim I understand anything about insurance. I really don't understand how they work and what decisions get made and why. I think why is there a task force and why is there guidelines from all the societies? How are they different? Why does that happen? I don't know. And it can be very hard. You know, when 3D mammograms first came out, that wasn't covered at all. People had to pay extra for it. Now, once Medicare adopted it, which was funny because those weren't useful in the Medicare patients. It was really useful in the young, dense patients. But once that happened, then coverage is now very standard. Now with AI, we just started artificial intelligent mammogram screening. We started that this year at my center. That's not covered. And in a few years, it probably will be. So, you know, as they understand that these things really are helping to diagnose and screen the population, you would expect coverage to follow. So I don't really have any good answers about why insurance covers what it does in these different guidelines. But I feel like as doctors, we understand the guidelines, we follow guidelines, and we make these calls saying you're not following the guidelines. And usually we get approvals, but not always. And that can be really frustrating and awful for us and for patients, of course.
Yep.
I don't know if that
Well,
answers
I
it.
think too, you know, each group has their own bias. So
Yeah.
American Cancer Society, we want to save every cancer, every life.
Right.
USPSTF may be more reactive and they're really looking for downstream harms. Let's not poke every lung nodule. Let's try and be really vigilant about doing things that improve survival. You don't do mammograms at 25 because it doesn't improve survival. And so I think they're tending the store. And I think many providers fall right in between. We can't be heretical about screening and send a grail off on every healthy person. But we also have to understand that some of these things will reach patients who can't be reached by colonoscopy, especially from a health equity lens. We don't have colonoscopy available in a lot of our sub-Saharan African countries. Maybe MCED will normalize that, so you can have a plasma-based assay or a blood test eventually that doesn't require a $2.6 million CT scan to be parked on your hospital plan. So Ajaratu, when you're dealing with the lower cancers, you know, I came across a statistic at one talk I attended from an American Cancer Society statistician that said $75,000 was a big cutoff for family income for screening. And you know, obviously per capita family income is much lower than that across the country, and much lower in some of the areas where we don't screen well. So if you make $75,000 as a family member or above, you're probably getting screened above 80% of the time for colorectal cancer. When you drop below 75,000, it's 39%.
Jeez.
Yeah, so maybe speak to that. How are you reaching those communities, whether they be communities of color, communities that are rural, communities that have lower socioeconomic status, or health literacy? Are there outreaches for those populations in your areas that you've had to be more creative with through, you know, the clinic that maybe the rest of us should be trying to emulate?
Yeah, yeah, that's a very important aspect for colorectal cancer, disparity based on socioeconomic status and racial disparity as well. And you know, there is definitely a disparity in the screening, and a lot of that we try to increase by having providers go out to communities and sometimes do pro bono, to be honest, like screening. I personally haven't done one, but I know colleagues who have done one. But I think, you know, having days like that, just having open access day with screening for patients from lower economic status or, you know, higher incidence of colon cancer, I think that kind of helps a lot. Or even if they can't, because colonoscopy, we keep talking about colonoscopy, but it's not just about coming in for the scope. You have to have someone else drive you. You need to take day off take a day off from work, and that all contributes to why some patients are not having this done. So the other screening methods are very important in that, and I think Cologuard is one that's on the rise, and I think that's very helpful. So even sending out cards to the boxes to their home, and it's just a stool study, right? They just go to the bathroom, put it in there, and send it back, and I think that could be, bridge some of that gaps for them, so they don't have to take time off from work and lose income, and someone else has to bring them and also lose an income. So I think that's a nice way to bridge. And I think for patients from the lower socioeconomic, I think that'll be very helpful in doing that.
Yep.
We have in the state of Maryland, we have the Women's Health Protection System, where women without any insurance can get an annual screening mammogram every year. And there are centers set up in like inner city areas or harder to get to. I'm out in Towson, which is up from the city, and it's, impossible for patients to get up here. It's all highways. You don't have a car. The transportation around here is not good, public transportation. So that group, most hospitals around here with breast centers work with to make sure women are getting screened. They have radiologists do pro bono work to read the screenings, which is wonderful because radiologists luckily can read, they read from home, they read at night, they read on weekends, so they can do that for that group of patients. Patients that do have abnormalities then can come see breast surgeons or go to the breast centers in town and actually get, recommendations, biopsies, whatever they need. It does get paid for by the state. It can be slow process. It can be very frustrating because you're like, hey, this abnormal mammogram was 3 weeks ago. Why haven't we done the biopsy yet? But it is at least one option in place to help with, disparities in care for patients that really have no support, no access, no money, no time, which is very difficult.
Yep. I know we got about 10 minutes left. I'm going to try and shift gears into more hopeful matters, future state and post-treatment. Stacy, you've had your 7,000 doses of FOLFOX. We leave you with side effects. Sam, you probably have to clean up the messes. Let's go back to the James and talk about these young adult clinics. The one unique thing for the patients that are now surviving, and when they're treated in the prime of their lives rather than very, very late, they're still very active people. Stacy has to go out for a run. Sam, when you guys have these younger cancer survivors, how are you approaching their survivorship? They're left with issues, not just the fertility issues that their doctors probably didn't talk about, Sarah, even in 2024, sadly, but they've got neuropathy. They've got physical deformities when they don't look as sexual a being as they might have because we've removed sexual organs. We've done things that have taken away their libido. We now give tamoxifen and Arimidex and others that may change their ability to participate in moments of intimacy with spouses, which I can tell you as a breast cancer doctor, something I ask about every survivorship visit, and it causes quite a stress. Do you guys have programs around this to help them put the pieces packed together after we push Humpty Dumpty off the wall?
Yes. And I think another thing that we are really trying to do, and we do in our assessment, is educate these young patients up front that we expect. Research tells us your distress is likely going to increase when you are done, because oftentimes these patients are suffering in silence, thinking I must be the only one, instead of sort of us telling them all along, listen, your treatment team's incredible, you're very connected. And oftentimes when you're not going to clinic as much and seeing those people, these sort of quality of life issues arise. And maybe you're not on short-term disability with the luxury of going to all the supportive care appointments anymore because you're having to take your limited time off to just go to your follow-up appointment. So we do have survivorship APPs. We have a survivorship clinic. We know sort of the physical therapy piece is huge. And we actually have a specific exercise program through our survivorship clinic where patients can have sort of 4 weeks of PT tailored to them, sort of figuring out what pain is sort of treatment based and needing to just have some personalized support around versus what may be something that needs like a pain clinic or a pain doctor. So really trying to tease out what some of those quality of life concerns are and then getting them to those providers. But we also know telling them it's coming sort of allows them to prepare instead of waiting too long for intervention. So right up front from the assessment, we schedule them to come back sort of right before they're done to remind them of those things, but also to sort of introduce the services that may now be relevant, like sexual health counseling, giving more education around sort of vaginal moisturizers and pelvic floor PT, because when they're deer in headlights, even if sort of they were given that information, there's no way they're going to have retained it by this point. We have like career counseling, because a lot of times these patients need help knowing what their legal rights are in terms of accommodations at work so they can attend these appointments. But yes, we absolutely address it right up front, but then try and proactively schedule them to come back right before the end so we can kind of re-educate and then connect again at that point.
Another question on those friends, because I know we're running out of time. Any of you guys support patients with younger kids who don't have reliable healthcare? So we've talked about that early on. We've got some space. We were a little nervous about caring for patients' children and running kind of a daycare facility while they're getting their infusions. Have you guys, any of you come across anybody doing that well?
No, and that's a great idea.
Yeah.
Yeah.
We've had a lot of conversations about it. There are quite a few barriers in terms of making sure patients have choice with their care and sort of keeping up on access, because if you find a place that you can sort of connect with, then transportation can be an issue, or car seats, or closing times if the patient has a reaction. We are absolutely exploring it, but sort of to this point, the best thing we've come up with is kind of providing that financial resource for patients to be able to access their own childcare versus being able to provide something as an institution.
Yeah, we've been exploring the same, and we've actually been talking about expanding to weekend hours. It's going to be a heavy lift. We're a 5-day-a-week operation. We do infusions on Saturday and Sunday mornings for people who need them, but to expand to a full service operation where our patients need us to be, many working moms and dads would love to have access to their chemotherapy infusions on a Saturday afternoon.
Yeah.
But again, logistics of staffing and other have been making that kind of hard to do. Maybe a final question, as we're getting close. Maybe
Dr. Flora,
go ahead, Stacey.
I just really quick wanted, I saw this question on the sheet and I just had to come in on it. First of all, Sam, thank you for everything you're doing, because I just have to speak very personally to this as a colorectal cancer survivor. Nobody told me about LARS, lower anterior resection syndrome. That was something I found out from an advocacy organization called Fight Colorectal Cancer. And it was actually a colorectal cancer surgeon at Ohio State who was talking about it on a webinar. Nobody told me about that. Nobody told me about chemo eroding my teeth. I had to invest thousands of dollars in reconstructive dental work. Nobody told me about radiation coming through and breaking my rib. So I want to just say that, and I'm going to be very blunt here, the money is in the treatment, right? There's not a lot of money in survivorship, much like advocacy, it's a mission. So I want to thank you for what you're doing, because nobody told me about the after effects of treatment that I am coping with and dealing with. And again, I'm like the healthiest person I knew going into this. So just want to thank you for that support. And I was also the person who had to juggle childcare going through treatment and walking around those treatment bays looking for anybody as young as me. It was very lonely, very isolating. And that flexibility would have been really helpful. So thank you. Thank you for what you're doing.
Sarah, there's a good one for you if you look on the Q&A section, maybe to type an answer, because we're running short on time. But yes, there are great resources for that for our anonymous attendee who's asking about sexual issues, joint pains from medications. That's a very common question that we deal with. And there are some good resources that we can put you on probably for the in writing and maybe share links. But I know we're coming up on it time-wise. Maybe one last thing, and I'll send this to Adratu. What are you most excited about for the future of this? We are making inroads with new studies, new screening tests. We've mentioned AI. I'm a big fan of that since I'm an editor-in-chief of an AI journal. I can promise you we are getting better screening and detection than we've ever had before this year. And next, as we do the MCEDs, as we're getting augmented endoscopies that are now putting red boxes around areas that endoscopists should be biopsying that are invisible to human eye. Sarah mentioned mammography, MRI, germline mutation screening, all this stuff. To take us 5 years in the future, if you will, and postulate what would you imagine we're looking at in terms of young cancer patients, and how we can do this if we all get this right together with the ACS, with all of your systems, because I'd like to be more hopeful as we close in the last couple minutes.
Yeah, for me, I think I'm most hopeful and excited for the possibility of non-operative management for cancer, so colon and rectal cancer. Um, there's data on immunotherapy that's mostly for patients with something called MMR deficient cancer, and they have very good response to that. So for rectal cancer, that's made a huge difference. And for colon cancer, they're mostly using it for metastatic disease. But I think if we can kind of continue the research and identify markers that allows other patients to be treated and come up with therapy that allows other patients to be treated with something like immunotherapy. So basically ramping up your own natural immune system to attack the cancer, I think that will be the game changer in terms of side effects affecting having all these consequences from treatment, like Stacey was mentioning. I think that could really make a huge difference. And for the most part, means that my job, I do less as a surgeon, but I think for the most part, it will be very make a difference in diagnosis and treatment of cancer.
That's great. That's a perfect close for us. I'm putting the one of the trials that she's just alluded to with 100% complete remission rate with immunotherapies in a selected patient population. That was a big deal in our world, and it made the lay press as well, speaking to how we can be smarter in our therapies and not harder. I think Stacey would have appreciated that, to have immunotherapies for a few months to downstage the cancer rather than all the 6 weeks.
Yeah,
of
let's go MSS. MSS, let's go.
That's it. All right, I think that's all the time we have. I'd love to thank our sponsors, James, United Health. Thank you for the American Cancer Society and Casey and team for putting this together. Thank you to our panelists, and I will turn that back over to Desiree to take us home.
Thank you so much, Dr. Flora, and our panel members. That was a great discussion, learned so much, and it was fantastic. Thank you for all your insight. So it is a priority of the American Cancer Society and National Colorectal Cancer Roundtable to uncover barriers and develop tools to support colorectal cancer screening, because we know screening and early detection can save lives. So this led to our interest in understanding what types of tailored messages could heighten awareness around the importance of on-time and regular screening. So the ACS NCCRT Lead Time Messaging Guidebook. It's a tool to encourage on-time colorectal cancer screening, and it's intended to provide you with information and tools to motivate individuals at average heightened risk for colorectal cancer to discuss screening prior to recommendation screening age. So it's my pleasure to introduce you to Emily Bell, Director of the National Colorectal Cancer Roundtable, to share more. Hi there, Emily.
Hi, Desiree. Thank you so much to everyone for inviting me to be a part of this program. This has been so informative and really interesting. So as Desiree shared, I'm with the National Colorectal Cancer Roundtable. We're one of 6 mission-critical roundtables at ACS. And I'm here to share with you today a little bit about one of our resources that was developed to try to address catching some of these early onset cases earlier. So first, just a really quick high-level view of the National Colorectal Cancer Roundtable, in case you're new to our work. We are essentially a coalition made up of over 200 member organizations. And our mission is to reduce the incidence of and mortality from colorectal cancer, with our main focus being on increasing screening. We actually have 3 priority areas right now, and one of them is on-time screening. So ensuring that patients get screened right at 45 or earlier if indicated. So I definitely welcome you to check out our website, nccrt.org, and even to consider becoming a member and participating in some of our programming if it seems like a good fit for you. Stacey Hurt and some of the others on this call have been longtime engaged partners with our work. So we really appreciate your voices and all that you contribute to our work. So next slide, please. So as the screening age for colorectal cancer dropped to age 45, starting in 2018 with the ACS guidelines and then 2021 with other major guidelines, we really identified a need to understand what are the best practices and messages that we could use to ensure that patients get screened on time at 45 or earlier if needed. We actually know that even when the screening age had been 50 for many, many years, only 50% of 50 to 54-year-olds are up to date with screening. And for the age 45 to 49 age group, currently it's around 20% screened. So we have a huge opportunity to get the message out there leading up to the screening age of 45 to ensure that patients know that it's so important to get screened on time. So that was the impetus to create this toolkit. We engaged in some market research, talking with 20 to 44-year-olds to understand what they know about colorectal cancer, what they know about screening, what messages would resonate with them and what channels are best to reach them. Next slide, please. So some of the key takeaways is that there is an education gap. They are not necessarily aware that age 45 is the age to start screening, not necessarily aware that if there's any family history or certain medical conditions that they should potentially get started earlier. There was an appetite to be told about screening before the screening age. So to have some time to start learning about it, start engaging with the ideas so that they're ready on time. They also generally agreed that they should get screened on time and were open to that idea. We also found that people were not just looking for quantitative info, they wanted messages that resonate with them, compelling stories about why they should get screened that really sort of deliver both the medical information and draw on their emotions to make them want to get screened on time. And then high on the action list is that people really wanted to hear this information from their doctors and clinicians, and that they're motivated to get screened when it's recommended by one of their clinicians. Next slide, please. So this is just one of the top recommended messages that really resonated with this audience. This one is, colorectal cancer is often a silent disease. Usually there are no symptoms. That's why getting screened is so important. Regular screening can help prevent colorectal cancer or catch it early when it's easier to treat. Most people should begin screening at age 45. So what we found is that this message really resonated because it explained that colorectal cancer can happen with no symptoms whatsoever, which is why screening is so important, and that screening should start at age 45. And then lastly, it also resonated that colorectal cancer screening is not just about catching cancer early, that it can also potentially prevent cancer. So this one and other messages that you'll find in the guidebook really resonated and could potentially help prime people so that they're ready to get screened on time. Next slide, please. So lastly, I just wanted to share with you that the lead time messaging guidebook, which is available for anyone to use, whether you're a member or not, is available on nccrt.org. And we also have a resource center. We have other messaging guidebooks based on market research that we've done on reaching particular populations for screening. We have what we call our STEPS guide, a manual for increasing quality, timely colorectal cancer screening in primary care, and other tools and resources that you can use either in clinical practice or share with community-based organizations, health plans, other partners that you work with, because we all play a role in increasing colorectal cancer screening. And then again, there are other roundtables at ACS that focus on the other cancers where we see early age onset disease. And many of these strategies really cross over between the different cancers. So definitely recommend you check out our site and the other roundtable sites as well. So thank you so much.
Thank you so much, Emily. So appreciate it. Great info. So as you may have gathered from our discussion, there are still many unanswered questions about cancer and its causes. The American Cancer Society Population Science Department uses the collective expertise of epidemiologists, biostatisticians, behavioral scientists, research analysis, and study management experts to better understand the behavioral, social, physical, environmental, and social factors that are that affect cancer prevention, risk, treatment, and survivorship. So we do this by comprehensively collecting and evaluating data from large prospective cohort studies, such as the cancer prevention studies. So before you go today, we wanted to share our latest efforts, which just launched last week. Voices of Black Women builds on this robust legacy of the American Cancer Society and addresses the limited racial and ethnic diversity in our previous cohorts and in health studies more broadly. This is a groundbreaking study. And now I want to introduce you to our American Cancer Society researcher, Dr. Lauren McCullough, to talk more about it.
My name is Lauren McCullough, and I'm visiting scientific director at the American Cancer Society Department of Population Science. For the last 12 years, I've had a near exclusive focus on cancer health disparities and minority health, largely focused on Black women who have often been underrepresented in medical research and who have not benefited equitably from decades of medical advancements. Black women have a lower life expectancy, higher rates of comorbidities, and among the greatest poverty rates of any other racial or ethnic group in the US. With few exceptions, Black women are more likely to be diagnosed with late-stage cancer, aggressive tumor types, and have higher cancer-specific mortality rates than other women across racial and ethnic groups. It is with this context that the American Cancer Society is launching Voices of Black Women, demonstrating our commitment to better understanding how minoritized groups are disproportionately impacted by cancer and other health outcomes. We aim to partner with 100,000 Black women between the ages of 25 and 55 who have not been diagnosed with cancer except basal or squamous cell skin cancer, and who live in one of the 20 eligible states plus DC. These states were selected because they represent 90% of the Black US population. Potentially eligible participants should go to our website, voices.cancer.org, to confirm their eligibility, consent to be a part of the study, and fill out a short registration survey, which will capture basic demographic information, enabling us to follow women over the course of 30 years. We anticipate this process should take no more than 10 to 15 minutes. Then participants will be asked to complete a life and health history survey that includes additional questions on demographic and health-related characteristics, behaviors and lifestyle, and mental and emotional health, including experiences of racism and discrimination. This self-paced survey can take anywhere from 60 to 90 minutes and can be completed in one sitting. Over the course of the 30-year follow-up, we will ask participants to complete 2 30-minute surveys each year to update us on their exposures and health-related conditions. Ultimately, after enrollment, a 1-hour commitment per year will help yield significant advancements in understanding the health of Black women. So what can you do? If you're a Black woman between the ages of 25 and 55 without a history of cancer and living in one of our eligible states, your voice matters. Go to voices.cancer.org to learn more about the study and enroll. If you do not meet these eligibility criteria, we ask for your partnership in helping to spread the word. Again, go to voices.cancer.org to download flyers and inquire about how you can engage and activate your local community.
Thank you so much, Dr. McCullough. So we hope you'll want to learn more about the Voices study as described by Dr. McCullough. So please visit, as she had said, voices.cancer.org to learn more. So we just want to remind you, our next virtual forum is on July 25th. We will be discussing navigating social determinants of health. The CME certificate for this session will be sent out in 2 weeks. And once you've completed the post-event survey, and that survey will pop up at the close of today's session, and you will also receive a post-event email with the recording of the session and the survey link in case you missed it this morning. We can't thank you enough for joining us today. Thank you to our panelist and Dr. Flora, and thank you for your commitment to end cancer as we know it for everyone. Have a great day. Bye-bye.